In this video, I will talk about the preferred IV fluids in some common diseases. If the patient presents to us with vomiting, if he has mild to moderate vomiting with no severe dehydration, the preferred IV fluid is normal saline as it replaces the extracellular fluid loss, mainly sodium and chloride. When the patient has severe vomiting with signs of dehydration or alkalosis, we can add potassium chloride in normal saline because vomiting causes hypocholeremic metabolic alkalosis and potassium loss, so we have to supplement normal saline with potassium chloride. If patient has a persistent vomiting and starvation, then we should add DNS with potassium chloride. Here the glucose is added to prevent the ketosis and to supply the energy to the patient. If patient has vomiting with hypoglycemia or poor oral intake, then any dextrose containing fluid like D5 half normal saline can be used as it provides glucose and adequate hydration. In children, D5 half normal saline and KCl are usually preferred fluid as maintenance, and they also correct the deficits. If the patient presents with diarrhea, in mild to moderate dehydration, the oral rehydration solution is the first line if the patient can take orally. Severe dehydration, or if the patient can't take orally, then the RL is preferred as its uh, composition is closest to the intestinal fluid loss, and it helps in correcting the acidosis. If RL is not available, we can use NS also as it is a good acceptable alternative, but it may worsen the acidosis slightly. If the patient has prolonged diarrhea with potassium loss, then we can use RL or NS, and we should supplement such patients with potassium chloride, and we should replace the potassium once the urine output is confirmed. In pediatric diarrhea, those of moderate to severe cases, RL or NS bolus can be given, then D5 half normal saline with potassium chloride can be given as maintenance fluid, and glucose is added just to provide energy to the patient. If the patient has a cholera or has rice water stools, then RL or NS can be given along with bicarbonate in severe acidosis. Here, because high volume losses in cholera leads to bicarbonate loss, so we have to supplement such patients with bicarbonate also. If the patient presents to us with burn, we should always use Sparkland formula for resuscitation in first 24 hours, and the preferred fluid is ringer lactate as it closely resembles plasma and further buffers the acidosis. In patients of diabetic ketoacidosis, we should always start with normal saline. Thereafter, we can switch to D5 half normal saline with insulin to prevent hypoglycemia. In any patients of metabolic acidosis, for example, due to diarrhea, decay, we can use ringer lactate or normal saline, but RL contains lactate which converts to bicarbonate in such cases. In patients with hypovolemic shock due to various reasons, whether they are external fluid losses or internal fluid losses, the preferred fluid is normal saline or ringer lactate. And rationale for using these fluids is the isotonic fluids, they restore the intravascular volume rapidly. We should always note that RL is preferred in trauma because there is less risk of hypercholeremic acidosis, and NS is preferred in brain injuries. In patients with septic shock, the initial resuscitation dose is 30 ml per kg of normal saline RL. Here we use balanced crystalloids like RL, Plasmolite. They are usually preferred over normal saline. In patients of hyponatremia, mild cases of hyponatremia, normal saline usually suffice. In severe and symptomatic hyponatremia, we should use 3% hypertonic saline as it, and we should always remember we should correct slowly hyponatremia because there is a risk of developing central pontine myelinosis if we correct it fast. Patients with hypernatremia, we should use dextrose 5% in water or half normal saline. We use hypotonic fluids because it lowers the serum sodium, and we should always correct it slowly to avoid the cerebral edema. In patients of chronic liver disease with ascites in whom we are planning for a large paracentesis, we should always supplement these patients with albumin. If albumin is not available, we can use normal saline or RL cautiously, but we should monitor the sodium and the volume status of the patient closely. In patients of hypoglycemia, we can use a bolus dose of dextrose 50%. We can give it as 50 ml of 50% dextrose IV bolus. In patients with raised intracranial pressure, normal saline or hypertonic saline is preferred. We should avoid hypotonic fluid because they worsen the cerebral edema, and hypertonic solution can reduce the intracranial pressure. We should avoid hypotonic solution and dextrose containing fluids because they worsen the cerebral edema. In perioperative and postoperative periods, the preferred fluids for maintenance are isotonic fluids, that is NS or RL. They maintain the intravascular volume and electrolyte balance. In patients with hyperkalemia, the preferred fluid is normal saline. We should avoid RL because it contains potassium, and in severe cases of hyperkalemia or in patients with renal failure, we should avoid RL. This is a generalized treatment for hyperkalemia. For cardiac membrane stabilization, we usually give IV calcium gluconate to prevent the arrhythmias. For shifting potassium into the cells, we use IV insulin, and with dextrose, beta 2 agonists like salbutamol inhalation, sodium bicarbonate if the patient has severe acidosis. If we have to remove potassium from the body, we can use loop diuretics, and in refractory cases of hyperkalemia, we usually do the dialysis. We should avoid ringer lactate in severe cases of hyperkalemia or in patients with renal failure. In cases of hypoglycemia, which I have already discussed, the preferred fluid is 50 ml of 50% dextrose as IV bolus. It rapidly corrects the hypoglycemia, and it is preferred in severe hypoglycemia with altered consciousness. As a follow-up after bolus, we can use dextrose 5% water or D10 infusion to prevent the rebound hypoglycemia. Mild to moderate hypoglycemia or at risk are a patient who are not able to take orally or in starvation. We can use dextrose 5%, normal saline, DNS or D10, and they maintain the blood sugar and volume. In pediatric hypoglycemia, we can use D10 2 to 4 ml per kg bolus, then maintenance with DNS. Here we don't use D dextrose 50% because it is too concentrated for infants and children. In children with hypoglycemia, in patients with hypoglycemia and due to alcoholism or malnourishment, thiamine should always be given before dextrose to prevent the Wernicke's encephalopathy. Diabetic patients on insulin overdose, give them dextrose and monitor their blood sugar closely. They may need D10 or D20 infusion. We should always check random blood sugar before and after treatment. We should monitor the unconscious patients and also assess the underlying cause of this hypoglycemia, whether they have insulin overdose, sepsis, adrenal insufficiency, liver failure, if they have any history of alcohol use. In patients with hypocalcemia, if the patient is symptomatic hypocalcemia like he is having tetany, seizures, or arrhythmias, we can use 10% calcium gluconate IV over 10 minutes, then infusion. It is an immediate correction. Follow up, we can use calcium gluconate in dextrose 5% water or normal saline, and it maintains the calcium level. In cases of chronic or mild hypocalcemia, we should use oral calcium or vitamin D. We should avoid ringer lactate in hypocalcemia because oral contains calcium and it is not suitable for IV calcium mixing. There is risk of precipitations. In patients with hypocalcemia, in chronic kidney disease patient, we should use calcium acetate or calcium carbonate and vitamin D analogs. Hypocalcemia may be accompanied with hypomagnesemia. We should give IV magnesium sulfate and calcium in such patients. We should always correct the magnesium before or along with calcium if it is low. We should monitor for bradycardia, hypotension, ECG changes. The ECG changes in hypocalcemia is QT prolongation, bradycardia. We should not mix calcium and bicarbonate in the same line as there are chances of precipitation. In patients with hypercalcemia, moderate to severe hypercalcemia, where the serum calcium is more than 12 milligram per deciliter or the patient is symptomatic, we should always use normal saline at higher rate because it corrects the dehydration and promotes calciuresis by dilution and increased GFR. Patients with volume overload, especially elderly cardiac patients, the NS should be used cautiously. We can use loop diuretics like furosemide. It prevents the fluid overload while promoting the calcium excretion. Mild hypercalcemia, oral hydration is preferred. If there is severe hypercalcemia with renal failure or refractory to fluids, the dialysis with low calcium bath can be used. We should avoid ringer lactate in hypercalcemia because it contains calcium and can worsen the hypercalcemia. In patients with hypokalemia, mild to moderate hypokalemia, oral potassium is preferred. If the patient is unable to take orals or potassium, or patient is symptomatic with palpitation, weakness, arrhythmia, then we can give IV normal saline with KCl. Severe hypokalemia, IVNS with uh, KCl is preferred. Hypokalemia with alkalosis, KCl is preferred. Hypokalemia with acidosis, potassium acetate and potassium bicarbonate, they should be given as they correct both potassium and bicarbonate deficits. Just remember one thing, in peripheral line, maximum potassium can be given is 10 to 20 milliequivalent per hour. If the patient is on central line, then we can increase it up to 40 milliequivalent per hour with continuous ECG monitoring. We should always dilute the potassium chloride in fluid and we should never give it as a IV push. We should always check renal function and urine output before giving potassium. When we are giving potassium, we should look for ECG for U waves, flat T waves, or arrhythmias. If the serum potassium should be monitored every 2 to 4 hours if the patient is on high dose IV potassium. Magnesium level should be monitored because hypomagnesemia can worsen the hypokalemia. With this, I conclude my today's topic. Thank you.